Anyway, cardiovascular, whatever that means. It's got two parts, cardio and vascular, it means heart and blood vessels. Okay, so, speaking of big words, you know, this is yet another medical term. It has a couple of variants which are kind of interesting. Electrocardiogram, I think some of you have heard this abbreviated as EKG. Anybody had one? Oh, yes. I had all kinds of stuff. Good. EKG, we'll talk about it more later, but it's just placing electrodes on the chest, and you're looking for things like your heart rhythm and whether or not all the parts of your heart are working okay. You might do an EKG on the patient. Okay. Or you do EKGs on a lot of people just for, if you're, say, participating in volunteering for some clinical study, they may hook you up to an EKG just to see if everything's okay. So we do a lot of them. Electrocardiogram, and again, it's one of these words you can break down and kind of figure out what it means. The electro part, electricity, right? Cardio has to do with the heart, and then gram, like graphing, means making some kind of a picture or some kind of documentation of the process. So you can do this, you can actually record these electrical impulses from the heart, and traditionally it's done like this, and these days it's a digital representation that gets displayed, but back in the old days, like everything else, you used a moving pen that was driven by the electrical voltage from the recording instrument, and you see there's 1, 2, 3, 4, 5, 6 here. There are 6 leads in this particular electrocardiogram. The little bumps and grooves and timings that you see here is a recording of the electrical, what we call the vector, the electric vector of the heart as it moves around during a single heartbeat. So it's an electrocardiogram, or EKG. Why do we call it EKG when we got a C in here? And this is because the device itself was developed in Germany, in which the German variant is this, okay, like with a K. And in the United States, we just call them EKGs, even though it's spelled a little bit differently. Just to keep in mind, you will always see it in journal articles and stuff written in English, written this way, but abbreviated typically this way. People can call this an ECG, but then you mix that up with the EEG, which is an electroencephalogram, which is something totally different. So EKG is what people say. Okay, so look at the cardiovascular system as a whole. Of course, the center of it is going to be the heart, but coming out of and into the heart are all the blood vessels. And I think this is a very useful diagram to memorize and get a good conceptual feel for, because it's not exactly intuitive, but it makes sense. A lot of the things, a lot of the biological and mechanical systems that evolution developed for us are sensible. Okay, they do things that may be complicated, but they make some sense. What you want to do is you want to take blood that has been through the lungs and contains a lot of oxygen and low carbon dioxide. You want to put that out into the peripheral tissues and this so-called arterial side here. And you want it to go into the capillaries where it can be delivered right to the tissues that need the oxygen. And then you're supposed to be, as we saw before, pick up the carbon dioxide and move that back to the heart and then pump it back into the lungs where it can get reoxygenated. So we typically call the oxygenated blood the arterial side, and on the venous side you have deoxygenated blood, which is rich in carbon dioxide. But that's not really the proper way of terminology, because you'll notice that is backwards. Arteries and veins are backwards in the lungs. Okay, so the true definition of an artery is a vessel that leaves the heart. The true definition of a vein is a vessel that goes back to the heart and enters the heart. Okay, so that's the way they're named. So you have the pulmonary artery, which contains deoxygenated blood, like all the rest of the veins in the body, but we call it an artery here as it leaves the lungs and goes back into the heart. So that's pulmonary artery, pulmonary veins rather. Okay, so pulmonary artery is going to be, it's going to be leaving the heart. Right? It's going to go to the lungs, the heart. Okay. And the aorta here, that's a big artery. Okay, but the pulmonary veins are also going to be, they're going to be leaving the lungs. Okay, so going back to the heart. So they're veins for that reason. Okay, so that's the loop. Okay, memorize the loop. Know what goes on in it. Okay, arteries and veins have kind of a general structure, and I guess they're all tubes. Okay, like any other tube. You use a pipe or something to carry something. So you're going to be carrying blood away from the heart and then back to the heart. So you do these in arteries and veins, and they have similar structures. And you look at them and you say, well, they look the same sort of. How do I tell one from the other? They have the same kind of, they have muscular structures here internally and externally. They have adventitia. The way you tell them apart is you look at the size and you look at some of the other features that they have. For example, in an artery, this muscle layer here is pretty thick. Okay? Why? Because in the arteries, you need to really change the caliber, not of the really big, large arteries, but as you go down into the small artery level, you need to be able to change your flow so you can relax or contract this smooth muscle ring here. So it's thicker in the arteries, and it's not so much, it's kind of vestigial in the veins. We don't really move the veins in terms of their caliber very much. The other things, the arteries tend to be a little smaller, okay? The veins a little bit larger. But the big feature that distinguishes them is valves. Okay, and we'll see why the valves are good a little later when you get into the physiology. Basically, they're kind of passive valves. They open and close with the direction of flow in the veins, and we'll see what they're good for. We'll see that this is going to be a high pressure system, which is another reason to have this pretty thick, smooth muscle layer. This is going to be a low pressure system. Okay, so that's the difference between the arteries and veins. So as you get down into the very, very small artery level, they have another name. They are called arterioles, okay, as they come in. And the arterioles, again, have this ring of smooth muscle. And they have right before the capillary that goes off here, they have this specific muscle called a precapillary sphincter. And the sphincter is any ring of muscle that opens and closes. Okay, the sphincter. We'll see all kinds of sphincters all throughout the body, but this particular one, little tiny arteriole, has this little sphincter here that closes and opens this capillary. So you got millions and billions of these capillaries, and they're all able to individually control their own flow. And this has been called the winking, blinking theory of blood flow regulation in all kinds of body organs. It's especially important in the brain. Okay, the brain is an organ, like the kidney and the liver and everything else, but it has that specific property that it needs to be able to regulate its blood supply in specific areas as needed. Okay, suppose some of you are sitting there with your eyes closed, but you close your eyes and your occipital lobe didn't do it very much. It doesn't need to. You're not seeing anything. You open your eyes, the blood just rushes into your occipital lobe on the capillary level. Occipital lobe starts metabolizing a bunch of glucose because you need it to get your vision. Okay, so you need to be able to regulate blood supply on the capillary level, and this is how it's done. You have all these little tiny capillaries, and again, they emit one red cell at a time for oxygen and carbon dioxide exchange. As they come out, as the blood comes out of the capillary system, okay, it goes in this little venule here. Okay, that's the equivalent of an arteriole. It's called a venule with a U-L-E at the end. Arterioles, little venules. So you can take a cross section through tissue. Okay, you can look at it under the microscope, and you can see this. And what you'll notice is that the smaller vessels, the arterioles and the venules, which you see depicted here, they're in pairs. Okay, they travel in pairs all the way up from the large arteries with the return vein coming back in pretty close physical proximity. It's just the way the system was, I won't say designed necessarily, this way it developed, where you have this pairing of the blood supply going into the tissues and coming back. It's paired on all levels. So you have a vein here, which is larger than in its cross-sectional area here in the little artery. And you notice this ring of smooth muscle around the little artery is much larger. It's almost non-existent in the vein here. Doesn't need it because it's not going to be part of the flow regulation process, whereas this is. That's the difference. If you take a snapshot, or somehow you're able to measure all the blood volumes and all the parts of the cardiovascular system, you do that, and these people have done experiments to do that, but you can see how this is distributed, all the blood volumes. Okay, this is the pulmonary loop. This is the blood that is in your pulmonary arteries, pulmonary veins, and your lung capillaries. It's only about 12%. Okay, at any one time. That's the volume. The flow is very high. The flow is 100% through that loop. Okay, but the volume is relatively low compared to the rest. The heart itself, only 6%. The arterioles and arteries, only 11%. All these big vessels that you have to supply blood to your body, only here. Capillaries even smaller. These are so small, but they have huge flow, through them. Every time your heart beats, all that blood's got to go through the capillaries. So it's a relatively small volume, but high flow. Most of the blood in your body at any one time, if anybody ever asks you on an exam question, hint, it's going to be about 2/3 of it, 66%. It's going to be in the systemic veins and venules. These vessels are sometimes called capacitance vessels because they have the capacity to hold all this blood. You'll all have taken some kind of basic electricity and magnetism course, right? So you know what a capacitor is. Holds charge, so they call these capacitance vessels because they hold blood. Okay, so most of us there, just sitting in these major veins and venules. And here's a couple of these diagrams that are from the book, and they're all marked up. These are the arteries here on this side, and these are the veins depicted in blue. It's kind of typical the way people make these diagrams. They believe that the arterial blood to be bright red, which it is. So they draw it that way, even though it's backwards in the cardiopulmonary system. But the veins are blue here. I think for the purposes of this course, we're going to not talk so much about the veins down below the pelvis here, way down in the extremities. We're not going to look at the arteries and veins down there too much. We'll look at some of the arms. They're a little bit more, from our functional standpoint, a little bit more important because they feed our hands, which are pretty important to us. And also the brain. But you see, there's a whole bunch of names here. And, fortunately, everything's pretty symmetric. So you only have to remember half of them, because they're the same on the right and the left, and it's all left and right. But you have a bunch of arteries here. I think for the purposes of this class, I think it's important to concentrate. We'll focus on the ones that we need to know as we go through here. And so there'll be a lot of these. And so that's when it comes to memorization of these things. I don't want to memorize everything, but just the things that I'll talk about a little later on in the course. And that includes other parts, other body systems, because they all depend upon a blood flow. So we'll talk about a lot of the arteries in other contexts, not just in these two lectures. So anyway, that's what you should do. When I went to medical school, one of my professors said, this medical school, we're really good at getting the blood out there, but we're not so good at getting it back in terms of anatomy. And so the veins always kind of get short shrift in this. People it's kind of ignore them. No, because there's usually a vein for every artery, and who cares? You got to get it out there, and that's important. Getting it back, yeah. So we won't talk too much about the veins, but they're going to be similarly named with some important exceptions as to the arteries, and we'll talk about specific ones again that we have to we have to know something about. Okay, so don't panic too much about learning all the names of the arteries and veins. It's kind of like we're not going to name all the bones in the body. We're not going to name all these either. So you can kind of relax with that. Kind of, he says, until the exam. It turned out I lied. Anyway, I think we saw this before here. This is the heart as it sits in the chest. And, we're all kind of, you get your elementary school anatomy, you learn about the four chambers of the hearts and the valves and all the diagrams they show you this picture of the heart kind of face on. Doesn't sit that way in the body, and we've talked a little bit about that, but you can see the relationships of the heart with the sternum here. And the sternum really provides all the protection for the heart, and a little bit from the ribs. There are some valves named here. I don't need to know them instantly at this minute. We'll talk more about them in this lecture and in the next lecture, but we'll see what they do. So the heart, again, is sort of like a triangle. So it has a base up here, and it has an apex down here. And this apex is probably, along with this lateral wall of the heart, called the lateral wall. There's no medial wall, but there is a lateral wall for both ventricles, the right and the left. And these are the two parts of the heart that move the most during and to some extent the anterior wall move the most every time your heart beats. Okay, so we'll look at those in specific later on, and especially how we image that. We can image all these processes. Okay, so that's you get the idea now that the heart is not only tipped to the left and then twisted as it sits in the chest. I had this slide entitled Basic Coronary Artery Anatomy, and we'll learn a little bit about which coronary arteries feed which parts of the heart. This is a diagram that the cardiologists would use when they're talking about their nomenclature, the way they name coronary arteries. And so when I say learn these, I mean these are the important terms. Okay, and try not to get too confused by the terms that the anatomists use for these vessels, which are very different, and you won't ever hear a doctor call them by those names. They will call them by these names. And so, for example, the coronary arteries are called that. They are the first arteries that leave the aorta. Okay. This is a medical student question that they try to trick them with. They say, okay, which is the first artery that comes off the aorta? And so everybody's going to say the brachiocephalic trunk. And then they say, yeah, wrong. It's these coronary arteries. These are the first ones. And, it's important because the heart has to supply its own blood. And it does these through a left coronary artery and a right coronary artery. So you have this big one coming down here. This is the left anterior descending coronary artery. It is often abbreviated the LAD. They don't call it left anterior descending. The cardiologist is going to call it, and you'll hear him say LAD. And you'll know what that means. You have an artery going backwards here. This is called the left circumflex artery. It goes around here and it goes to the back of the heart, even though it's sort of drawn on the front in this attempt. But this LAD is very important because it supplies almost all of the anterior wall and much of the left. Okay, so then there's all these little diagonal branches that you see here, and they're called just diagonals. That's the way they refer to them. This big artery that comes off and feeds the left anterior descending coronary artery is called the left main coronary artery. The left main coronary artery is extremely important because what would happen if I block this artery off? Everything on the left side of the heart doesn't get any blood. I think this is one, or the one to the LAD, if you have a blockage there, is called a widowmaker. That's back when everybody thought only men got a heart disease. Not true. But they call it a widowmaker because it's usually quickly fatal. On the right side of the heart doesn't need such a huge blood supply because it doesn't pump near as much as the left side. We'll see how and why. But so you have a big right main coronary artery, or they just call it the right coronary artery. And then you have some other branches that wrap around to the back of the heart and feed the back. And then you have a bunch of what they call perforating arteries here that go into the septum, the interventricular septum. It's the muscle between the two ventricles of the heart. And they supply the septum. You say, well, the septum just sits there, why does it need blood? Well, we'll find out a little bit later. You can, so these are the names here. The book has, actually diagrams are better. But they call them different things here. For example, they call this the anterior interventricular branch of the left coronary artery. Okay, left coronary artery, that's okay, but the anterior interventricular branch, that's the LAD. It's, so the nomenclature is a little bit different, but this kind of gives you a better idea in 3 dimensions on the anterior and the lateral side of the heart about how these are formed. And we'll look at all the different structures in here in a few minutes. But in this particular diagram, you have what is called the ascending aorta. We've seen this in images before. It comes off of the left ventricle. Okay? This is called the root of the aorta here. Comes into the ascending aorta. Then it loops around this aortic arch. It's called arch of the aorta. Ooh, it's cool. Aortic arch. Then it goes down to where you can't see it anymore. It's called the descending aorta as it goes down through the rest of the body. It has 3 big branches off here. The brachiocephalic trunk. Anybody want to break that down? What does it mean, brachiocephalic? Big word. Once you break it down, you'll remember where it goes. Brachio means arm. Cephalus means means head. So the brachiocephalic trunk feeds the head and the head on the right side and the right arm. The left common carotid artery feeds only the left side of the head. The left subclavian artery, because it goes under the clavicle, feeds the left arm. Then there's all kinds of branches that feed other parts, but these are the 3 big branches that come off, normally off your aorta. Now, when I say normally, I think most of the people sitting in here have this anatomy. Some of you don't. Odds are. But it doesn't matter until, something bad happens, then it matters. But most of the time you don't. This is a so-called redundant system. You can have abnormalities in it, but it kind of fixes itself. So you have in here, going back into the heart from the lungs, you have these left pulmonary veins, and again they're called veins because they go back into the lungs. And the right pulmonary veins go into the right aorta. This auricle of the right atrium. The atrium is the chamber of the heart. Okay. Auricle is a word in Latin. It means little ear. Little ear. Somebody thought it's an appendage off the actual chamber of the atrium. There's a little bit of cavity within it where you can form blood clots and bad things happen. So the same over on the left. You have this left auricular appendage, auricle, the left atrium. And you have something called in the superior vena cava, and you can't see it here, but there's an inferior vena cava as well. And the inferior vena cava drains the whole bottom part of your body, and the superior drains the arms and the head, okay, and upper parts of the body. So that's basically it. But you can flip the heart around, and there's some. You do that, and there's some other structures back here that are of use. You've got the right atrium, which is a pretty posterior structure here. You have the inferior vena cava coming into the right atrium here. You have your pulmonary veins. You can see them much better here now. These are the veins that drain the lung and go into the right atrium. Okay. You have this great big vessel here called the coronary sinus. Again, the word coronary means something that, like coronary arteries, this is kind of like a crown around the backside of the heart. Whenever you see the term sinus in relation to blood vessels, just means a very large vessel where the flow is very low, almost stasis. Okay, but it's called, the other thing called the coronary sinus here is it's called the great cardiac vein, the whole vein here, and this area right in here is called the coronary sinus. That's where the blood kind of drops, to the flow gets very, very low. But we'll see why that's important later on. You have arteries and veins that go on the backside of the heart, on the right, but also on the left. You have the artery that comes around here. They call it the posterior artery of the left ventricle. It's really called a circumflex artery, is what your liver cardiologists call it. Okay. So it's pretty important for your movement and blood supply to your posterior wall of the heart. Again, you see your aorta coming up here and your brachiocephalic trunk, left common carotid, and left subclavian arteries, and then into the descending aorta here. Okay. So, again, kind of on this slide, I've kind of just said, okay, learn that this is called the posterior descending coronary artery instead of the name the anatomist gives. All right, is that kind of clear? We'll see all these structures again in their own context later. But, kind of just an introduction to how all this is put together. It's a complicated system because it's got to do a complicated job and an important job. Angiography, we've seen this word before, means taking pictures of blood vessels, right? Okay, so think, well, how do we do it? Okay, what's the procedure that we can use? And I think it's worth talking about because it's kind of universal. We do angiograms in all kinds of vessels, but angiography typically means vessels, but it's usually, they're looking at arteries. There are some circumstances when you want to look at the flow in a vein, but there's better ways to do that, like ultrasound, Doppler ultrasound, probably a better way to look at a vein and try to stick needles into people and catheters. But in many instances, if you want to look at not blood flow necessarily, but the anatomy of something, it's usually an artery. So take an artery that you can get to. Okay, I don't want to try from the outside to stick a needle into the aorta. I want to do that. I want to get something a little bit more accessible, and usually it's the femoral artery. Okay, and that's down in your groin. Okay, right. Down below your pelvis. And you have an artery, big artery and a big vein there, the femoral artery and the femoral vein. They run real close together. And pretty easy to find the vein. What you do, you find the artery first, and you know the vein is a little bit medial to that. Okay, so you find the artery, just put your finger there, you feel the pulse, then you stick your needle, don't stick it in the artery, the vein rather, you stick it in the artery. Okay, so there are instances where you want to stick it in the vein, but not for angiography. All right, so puncture the femoral artery, okay, and you put a catheter in. Okay, and the catheter is a long plastic tube. In the case of angiography, it's pretty thin. The caliber is maybe a millimeter or two. And so you put it into the artery, and you take that catheter, you just push it up through the femoral artery. It's against the arterial flow now, because your flow is coming down into the femur, okay, in the lower leg. You direct it against the flow, and you can put it up wherever you want it. And we'll see all kinds of angiograms. The example I'm here is the coronary arteries. If you want to do what's called coronary artery angiography or coronary angiography, this is what you do. Put them up in there. Then you can, after you do a few of these, you can take the tip of that catheter and put it into one of the coronary arteries. You say, well, doesn't that block the flow? A little bit. That's why you got to be careful not to leave the catheter in one place too long. But but what you're going to do is you're going to use that catheter to inject what is called a contrast medium. Okay, this is something that is opaque to X-rays. Usually contains, for the ones we use in blood vessels, contains iodine, which absorb the X-rays and gives you the contrast you need to see the vessels. If you just do you've seen it, if we just do an X-ray of a vessel, we don't see much. Okay, basically transparent to the X-rays, but with the contrast in, you can see it. So that's what we're going to do. How do we do that? It's called the Seldinger over-the-wire technique. And start out here on you. These are sterile procedures. Go into an artery, it's done sterilely. So if you ever have to go into where an angiogram is being done, you're going to have to gown up and put your mask on and all the other sterile gloves and stuff in this angiography suite. And you're going to take your catheter here, and depending upon where you need to go, the length of the catheter will vary somewhat, but it's usually, a meter or so. And here it's depicted all coiled up, but in general, you're not going to use it this way. You're going to uncoil it and snake it up. So how do we do that? Well, you find your pulse for your femoral artery, or you can also use other arteries. You can use a radial artery. That's the one, as we'll see, it's going down here in your wrist. You can use that. But mainly use femoral artery. You stick a big needle in there, and over that needle is a plastic tube which you force into the artery. And then you take a long wire and you put it through the plastic tube after you've taken the needle out. Take through the plastic tube and into the artery. Okay, and goes up a little ways. Then you take your catheter and put that over the wire. And the wire is kind of a guide for get the catheter started smoothly into the artery. So you'll do that, and then you will keep that guide in there, and you'll take the wire out, and now you just got your catheter in the artery. And so then you can snake it up to the heart here, okay, and into whatever coronary artery you want to put the contrast into, inject the contrast. And the word that the cardiologists use for injecting contrast is called squirt. I'm going to squirt the LAD, is what they say. So if you hear that, that's what they're talking about. Squirt the LAD. So, and we've seen this before, so you can squirt whatever artery you want. Here's the catheter. Okay, this also has some contrast in it. Okay, and he's placed it here, and he's put the catheter right here, and he's squirted the left anterior descending coronary artery and all its branches here. So, anyways, how we do it, and we'll see angiograms in all kinds of other vessels, but that's the basic technique. Okay. All right, so seeing the outside of the heart, and I think it's more important what goes inside the heart. So you can take the heart. The way they've done is just cut it longitudinally here, and then flipped it open like the pages in a book. Okay, so you have your anterior side of the heart over here, your posterior side over here, and then you have your right ventricle here, left ventricle here, right ventricle over here, left ventricle here. So you have your four chambers. You have the right atrium, okay, and you have the left atrium. And you have your right ventricle and left ventricle, okay, and it shows here, shows some of your valves in this particular depiction. What are the valves for? Well, we'll see that it's important to have blood moving only in one direction. Okay, so the valves, some of the valves in the heart are kind of passive. Okay, they go in the direction of a pressure gradient. Others are active, where they may need to go under certain circumstances against a pressure gradient to be closed during parts of the cardiac cycle. So what they're showing you here is cordae tendineae. Tendon is cords, literally in Latin, fibrous cords, like little ropes. And they're connected to a muscle here that is called the papillary muscle. And there's several of them. They terminate in these chordae tendini, and the chordae tendini are attached to the valves. Okay, we'll see what they're good for later. But so if anybody asks you on an exam and it has this term in there, you'll know what it is, hopefully. Also papillary muscles. Okay, so, and again, they've indicated the aorta here. They call this the aortic semilunar valve. It's half moon in Latin. No one ever says this part. They just call it the aortic valve. Okay, and on the other side, which you see over here in the right ventricle, they don't show it, but you have another valve over here. We'll see them all in a minute, but pretty much the same structure. This is the interventricular septum. It is some kind of septum is in general this kind of a membrane or fission between two chambers. So you have a septum in your nose because you have chambers there. So you have a septum here, and you have all sorts of other septums. But they divide two chambers. In this case, it's called the interventricular septum between the ventricles. And it's muscular, like the rest of the heart. Okay, it's not just a membrane, it's muscular and capable of contracting to a certain extent. So that's the septum. Anything else here? You have your atriums. And then they have the right AV valve. This is what the anatomists call it. AV stands for atrioventricular. So you have your right atrioventricular valve and your left atrioventricular valve. Nobody calls them that. They call them the mitral valve on this side, okay, and the left side, and the tricuspid valve on the right side. Those are the names that you will hear and you will see written out. Unless you have another anatomy text, they may use the other two. But this is pretty descriptive. Left atrioventricular valve tells you what it goes between the atrium and the ventricle. That's nice and descriptive. But no one ever calls it that. Okay, so you have to be able to understand what the doctors are talking about when they do it. Okay, so that's your heart all flipped up and get an idea of how things are put together. But I think what's kind of important is some more terminology here. You know, the heart is beating, and the beating consists of two cycles. Okay, one where the heart is maximally contracted, okay, to eject blood from the left ventricle into the rest of the body, and from the right ventricle into the lungs, and that is called systole. Systolic. It's another adjective. It has to do with systole. Diastole, on the other hand, is when the heart is maximally relaxed. When I refer to the heart in this sense, I'm really referring to the ventricles. The aorta are out of phase with the ventricles in terms of cardiac contraction. And we'll see that a little bit more in a minute, but typically we're talking about ventricular systole and ventricular diastole. There is an atrial diastole and atrial systole, which is 180 degrees out of phase with the ventricles. That's what these terms mean. And they do give you some indications of the direction of blood flow here. It goes from during diastole, when the heart's relaxing, okay, the blood will flow from the right atrium into the right ventricle. And when the heart is, and from the left atrium into the left ventricle during diastole. During systole, the opposite happens. Blood is ejected from the two ventricles. The right ventricle goes to the lungs, and from the left ventricle goes out up the aortic root through the aortic valve and then out to the rest of the body. So, I think we'll see that. We'll see this multiple times here, both from an electrical standpoint and a mechanical standpoint. But this is what the two terms mean, basically. All right, diastole and systole. All the diagrams kind of show the valves kind of, in different places, but really it's kind of interesting how close together they actually are. You would think they seem to be kind of far apart because the diagrams kind of really separate the right and left ventricles, but really in 3 dimensions, and they're all on a single plane. They're all pretty close together. And so people have called this the valve plane. It is the official boundary of the base of the heart. And it's the base of the heart or the valve plane. So you can see your, they call this the left atrium ventricular valve, or everyone else calls it the mitral valve. This is the one between the left atrium and the left ventricle. And then on the right side, you have the tricuspid valve, which goes, separates the pulmonary artery from the right ventricle. And it shows them open here. And you can see right through here, you can see these chordae tendineae and the tricuspid and mitral valves on this side. And they got these valves are open during this particular cardiac phase, and these two are closed. And we'll see how that works in a minute. But now it shows the opposite during, this is going to be systole here. Excuse me, this is when the ventricle is contracted, this is systole. You have the mitral and tricuspid valves are closed during systole, and the aortic and the tricuspid valves here on this side are open. Tricuspid, excuse me, the aortic valve here and the, all right. Heart's got a wall, okay? Most of it is muscle, myocardium. You have the endocardium here, okay, the inside surface of the heart, and you have the epicardium, or epicardial surface, the outside surface of the heart. And in between them, you have this big, thick wall of muscle, and it has a name. It's called myocardium, muscle of the heart, literally in Latin. And separating those, you have this fatty connective tissue, they call it here, which has all the arteries and all those blood vessels we were talking about, all live in this space in here. But outside this space, you have this pericardial space here. Okay, you have what is called a pericardium, which is going to be a membrane around the heart. This is a single membrane goes around the heart. Like, remember the pleura goes around the lungs? Well, this is a membrane that goes around the heart. It's called a pericardium. And it has two surfaces. It has a visceral pericardium, which sits right on the heart. And then you have the fibrous pericardium out here, which is thicker. And then there's this potential pericardial space in here. And you remember that the pleura, the pleural space, has some liquid in it to provide lubrication? Well, same here. Okay, that's what the pericardial space is for. It has this so-called serous fluid, which is kind of like high protein blood plasma. It's pretty slippery. So it provides you some lubrication as the heart contracts. So otherwise your pericardium, you're scratching up against the cardiac surface, and that wouldn't be good. Okay, so you have those membranes. Then they show them again here. So this is pericardium here. The pericardial space is a potential space. That means it can get smaller or get bigger. There are conditions where this membrane can be inflamed. And the reaction to the inflammation will be to put more fluid into this pericardial space. Okay. And is that good? It's okay if it's not too much fluid. But as you get more and more fluid in there, what's going to happen is going to keep the heart from beating. Okay, so there are certain diseases where your pericardial space may fill up with fluid or it may fill up with blood. And that when that happens, your heart rate and heartbeat is constricted. So you can't get really sick. So they will have to go in and with a needle, you can go in through the chest wall and drain that fluid off. And that will help the patient a lot. Okay. That's a conduction system. To make this, you saw how we made striated muscle move. Okay, you remember a little movie about actin and myosin, troponin, tropomyosin, all that. And again, you have to have calcium. So the heart is the only part of the body where the involuntary muscles, the involuntary striated muscle, maybe a few little other tiny places, but mainly here. So striated muscle, and it has a conduction system to make it go. And starts out here in something called a sinoatrial node. That's because they call it that because it's in the heart tissue next to the atrium on the right, and next to that sinus that we saw on the backside of the heart, on the great cardiac vein, it had that coronary sinus. That's what they're talking about. And they got in parentheses here, pacemaker. Okay, it's a little bundle of nerves. Yes, that little bundle of nerves that can autonomously beat and put out impulses autonomously. Nerve, little electrical currents all by itself. Okay, you can. I don't know if anybody still does this. I think we're using animals for demonstration purposes less and less. But if you take the heart out of a frog, when you're dissecting a frog, you put it on a table next to a frog, it'll continue to beat. And it has the capacity to do that because it has this little sinoatrial node is still intact, and for a little while it'll continue to beat. So it's autonomous, and it produces little electrical impulses that go to something called the atrioventricular node. Okay, there's a nerve bundle that goes to this structure in here, the atrioventricular node, because it is sitting right between the atrium and the ventricles. That we'll see acts kind of like a delay box for that electrical signal, and it's a point at which you can control the impulses that come out of the sinoatrial node. Either slow them up, or maybe give them stimulus to speed up. So that divides into the left and right branches of the AV bundle. Okay, it's now the bundle splits up. You got two branches. One goes to the right side of the heart, and the other goes to the left. This little Purkinje fibers, these are all the little branches of the left and right atrioventricular bundles. This is what goes to the individual muscle cells in the myocardium. So it starts here, the impulse starts here, goes down the atrioventricular node, splits up here, and the impulse then goes all the way to all the parts of the myocardium. So this is how you propagate that impulse through that system. So you can take the heart and take it out, okay, and what you're left with is what's called a posterior mediastinum. The word mediastinum, for you medical physics people, I would remember this word, mediastinum. For the last 13 years, I've asked what it is on the qualifying exam, and I stand up in front of every single class and tell them this, and somebody misses it on the qualifying exam. So mediastinum is just that area of the chest where important things live. Your heart lives in the mediastinum. Your great vessels live in the mediastinum. There's big lymphatic ducts live there. Your esophagus lives there. A lot of important stuff goes through the mediastinum. And so remember that term. And it kind of gives you an idea here what things will look like. And again, this is a good way to review all the other structures we've talked about. Not only does it contain lymph channels, but there are lots of lymph nodes in the mediastinum. Because remember the lungs are a big interface with your environment. You got to have a lot of immune capacity right there next to the lungs. Okay, so you have a lot of lymph nodes, and they're called mediastinal lymph nodes. And the reason they're important is because they're needed to fight infection. That's important, but they also, from a medical physics and cancer treatment standpoint, these are where metastatic disease from the rest of the body winds up in the mediastinal lymph nodes. So lots of times you're going to be aiming your accelerator beams or other treatments to the mediastinal lymph nodes. Okay, you got to get the cancer out. All right. Look at some images quickly. I don't want to beat a dead horse, so to speak, here, but go over and over chest x-ray. But I think it's kind of important that you know what these structures are now that you've seen them. You have the trachea here, air-filled. Left and right mainstem bronchi you can barely see. But now you can see this left ventricle and the right atrium coming out here. These are, again, a two-dimensional depiction of this three-dimensional object. Apex of the heart's down here. Okay, it's behind the diaphragm. But then you have this costophrenic sulcus, which it should be sharp, as we see it here. And then your diaphragm here. So you can see a lot of this on just a regular chest ray. And you can see more of it when you do CT or MRI. Again, you don't see blood in these chambers of the heart because it's moving, okay, like it is in the other vessels. You can get all kinds of views as you go through your MRI here and look at these structures in other planes. Again, here's your superior vena cava, your right atrium. Okay, you see a little hint of your inferior vena cava coming up here as well. You see it on CT scans, not so well. You got to see anything on an X-ray or a CT scan, you have to put it in contrast. And we've done that here, and so we waited. Okay, this is a delayed phase here. We've waited after we inject the contrast for probably 30 seconds or so until all the chambers of the heart fill up. So you see them all filled up simultaneously. Right atrium, left atrium, aortic arch here, then you have the right and left ventricles. The best way, if you want to see vessels, you do angiography. And you remember the concept of the digital subtraction angiogram? Remember what you're going to do is you're going to take two shots, one before the contrast, one after the contrast. Record them digitally, inject your contrast, get your other image, and then have the computer subtract the two. And it's really important that you tell the patient to hold their breath and not to move so that you get the proper registration. Even when you do that, you're always a little bit off, so it's not a perfect subtraction, but it's pretty good. But what they've done is they've put the catheter in. You can see the catheter snaking right up through here. Dim the lights a little bit for you. I see a little bit better, but you can see the catheter coming up here and goes around down here, and he's injected contrast into the aortic root. Okay, so the blood flow is going to be this direction. None of it's going to go back into the heart on this particular real rapid phase of it, this very early phase. So the contrast is going up, and now you can really see nicely your brachiocephalic trunk. Common carotid artery goes to the left side of the head. The left arm has a separate branch called the left subclavian artery. Okay? And then you see all these little branches here. The right subclavian artery branches way off up here off the brachiocephalic trunk. Like I say, this is what we call the quote normal anatomy. Not everybody has it this way. So the variant of this. So this is an aortic arch arteriogram or aortic angiogram. Call it either one. You can do the same thing in the lungs. It's called a pulmonary arteriogram. You will hear this called a PA-gram, pulmonary arteriogram. And why do we do this? You remember the pulmonary embolism business? It's only a couple of days ago. Yeah, pulmonary embolism. Well, what you want to do, we saw it with a VQ scan, but the VQ scan isn't all that good in terms of resolution. It's really good in the physiology and can give you a good idea, but it can't really tell you where the clot is, if there is one. In this particular procedure, though, you put the catheter. In this case, they put it in through, I suspect from the direction that I see here, probably through the brachial vein and into the subclavian vein. Another way to put it in is directly right in here in the subclavian vein. We've done it here in the brachial vein. Goes down through, through into the right atrium, and then through the tricuspid valve, and then up into the pulmonary valve, through the pulmonary valve, and right into the main pulmonary artery. Inject the contrast, goes in both ways, And then they will look in all these, make sure it goes out into all these branches here, or if there's a clot here. And in this particular instance, you see a nice bifurcation here. Look at what happened here. This whole vessel is cut off here. So you got blood clots sitting there. And so these segments out here aren't getting the same blood supply that they would be over here. So this is what this is good for. Again, it's an invasive procedure. So you don't, want to go through, you don't want really, the patient to have to submit to this because again, it's risks of infection, bleeding, all sorts of other things. Okay, so you do the vessels of the head, all right? And as you come off on the right side, remember they have brachiocephalic trunk or artery coming off. You have your common carotid artery coming up through here. Okay. This will branch off into the internal carotid artery, which goes to your brain, and then the external carotid artery, which goes to the rest of the scalp and the skull and the muscles covering that, and that's the part we don't care about much, okay? We are mainly going to be concerned with the internal carotid artery. And the rest of it, of course, the face and everything else has to get blooded. But as we'll see in this course, and the physicians are mainly going to focus on the internal carotid artery. So let's not worry too much about the superior thyroid artery or all that. Not going to be too concerned with those at this point. The veins, the head and neck. Okay, the big vein that drains the head and everything else called the jugular vein. So like you have an internal and external carotid artery, you have an internal and external jugular vein that all again drain into the atrium on the right side. If you look at the drainage of the internal jugular vein from the brain, you have this big structure here between the two hemispheres of the brain. It's called the superior sagittal sinus. Remember I said that a sinus is usually a venous structure, has high capacity and low flow. And it's a good landmark. And we'll see it has some other functions that are interesting when we get to the brain anatomy part. But again, that's an important venous structure, but of course there are others. You have other sinuses. They have this one called a sigmoid sinus. Again, another low flow, high capacity part. And of course these are paired, so you have all this on the other side as well. The internal jugular vein has a use. If you want to put a catheter, another way you can put a catheter into the right side of the heart is to go through the internal jugular vein, as well as subclavian vein or brachial vein. You can do it that way too. It's actually a pretty straight shot and it's pretty easy. So people use it a lot. Plus it's more stable than the subclavian one. Okay, so those are the veins of the head. The arteries at the base of the brain are important. They're showing a whole bunch of arteries here, and they're naming them, and we'll look at some of them later on. But what they're focusing on is this structure right in here. They've teased it out here for you. This is something called a circle of Willis. It's the name for it. This is named by a guy whose name was Willis. Okay? I think he lived in like the 1600s. So, people were taking apart brains, pretty early. And so he got this named after him. And what it is a communication between two really important arteries, the middle cerebral artery here, okay, and on both sides, and these communicating arteries that branch off here. And what this does is give you some redundancy in blood flow. We'll see how that is in a minute. But it also loops into these other arteries here that feed the base of the brain and the cerebellum, and also parts of the spine. But we'll see that in a minute, how that works. But all these big arteries, like the middle cerebral artery and the anterior cerebral artery, the posterior cerebral artery, supply what are loosely called territories of the brain. We'll hear neurologists and they call them territories. So if you block off one of the artery, you will be depriving a particular territory of blood supply. The biggest, most important one is going with this middle cerebral artery and its branches that go into the parietal lobe of the brain and also the temporal lobe. We'll look at all the lobes of the brain later on, but So this is a really important artery, middle cerebral artery. You can do angiograms on it. Okay. You can stick a needle in, a little catheter in there, squirt your contrast into the internal carotid artery. That's the one that's accessible. And you all can feel it on yourself. Stick your hand on your neck where you feel a maximum pulse. That's going to be your carotid artery. And right next to it that you can't feel is going to be your jugular vein. But, so you squirt the internal carotid artery, and you can look for blockages there. But early on, you will branch off into the anterior cerebral artery here, which feeds the anterior portions of your brain, and the middle cerebral artery, which supplies everything else. And again, this is a very early stage angiogram. It's only a few seconds after you put the contrast in. You're putting it into the flow now. And so it fills up. Everything fills up pretty good on this side. You see nothing over here because you didn't squirt this internal carotid artery on the right, you squirted it on the left. So you don't see anything over here. If I want to see all this over here, go over here and stick my needle in this side. Do it again. But I don't want to do that. Instead, I can wait. Wait a few seconds or a few minutes, depends. And you'll notice that now this side starts going. And how's that happen? Well, that's the circle of Willis. That's his job, is to, in case you have blocked this right side off, for some reason, the whole right side of your head, you blocked off the internal carotid artery, you can still get flow to that side through the circle of Willis. Okay, so it's a backup system. It's a redundant system to get blood flow. Right? Okay, so it's these little communicating arteries here that you see kind of back in here that are giving you this redundant blood flow. So this is an anterior-posterior projection, and you can look at it laterally as well, and you can see the rich blood supply that this internal carotid artery and middle carotid artery are getting to all parts of your brain. Okay, the posterior, anterior parts, all of these others. Huge territory. That's why the middle cerebral artery is really important. And this is the one that often gets blocked off in something called stroke. Don't know that term. Okay, it's a blood clot that deprives the brain of oxygen. It's the equivalent of a heart attack. And the lay people call it a stroke. You can also introduce your contrast into more so you see better the circle of Willis, and you can see these cerebral arteries go here. I want everybody to memorize these. This is the posterior fossa. What's the posterior fossa? Remember, a fossa is a depression. This is a depression in the occipital bone. It's probably about this big. Okay. And yet, the anatomists have taken and named a zillion blood vessels in that little tiny space. And why is, it's not important that we know them, but this one to impress upon you. It's important that somebody knows them. If you're a neurosurgeon, you need to know where these are. You don't want to be cutting them. Okay, so you know where all these things are or about. So anyway, just kind of give you an idea of the degree to which we can do this stuff. All right, that's going to be that for now. Any questions or anything? Go back and review your diagrams about right and left and atria and ventricles. In the second part of this, we'll look at how all the mechanics and the electronics, work to make this the whole system, run to give you blood where you need to get it. Alrighty, well, okay, we will see you next time. I don't know if and when I'll get those exams graded. Maybe the end of the course.